You can start, Professor.
Thank you. So hello everyone and welcome. Good evening from Melbourne. I hope everyone's having an interesting day wherever you are. I'm Barbara McPake. I'm Professor of Global Health and Director of the Nossal Institute for Global Health at the University of Melbourne. And I'm also the incoming Chair of Health Systems Global. Welcome to the session. I'll be inviting colleagues from an interesting and diverse range of funding agencies to share their thinking about how funding priorities might, or for that matter might not, be reshaped in the wake of the COVID pandemic. We all know that COVID is turning every aspect of our lives upside down, even though our experiences of it are varying vastly from our different locations. And there was a very interesting earlier session today, which I'm sure many of you attended, in which the experiences of South Asia and those of Europe were being contrasted, for example, in relation to their universal health coverage and health security. But what will it all mean for research agendas? And how are the agencies who fund health systems research, but still have quite contrasting missions in relation to why they're funding health systems research, how are they all thinking about this? So first of all, let me introduce the panel in no particular order. May I introduce first of all Kamal Montasser, who is the program leader for health research partnerships at the International Development Research Centre in Canada. Benjamin Löwensen, who is senior technical coordinator for health systems at the Global Fund for AIDS, TB and Malaria. Lola Adedokun, who is the program director for the African Health Initiative at the Doris Duke Foundation. Feng Zhao, who is program leader in health, nutrition and population global practice for Europe and Central Asia at the World Bank. And Abdul Ghaffar, who is the director of the Alliance for Health Policy and Systems Research. Thanks so much to all of you for agreeing to take part in this panel today. And thanks to all of you who have tuned in to participate in the session. Please use the Q&A box to add your thoughts and ask the panelists questions as we go along. And I'll be doing my best to pick up on your thoughts in the conversation that we're aiming to have that follows. So I'm going to start by inviting each of the panelists to say a few words about the main issues that are guiding their agency's thinking about priorities in the COVID and post-COVID eras. Could I start with you, Montasser? Would you like to tell us about how IDRC are thinking about this?
Good morning, good afternoon, good evening, everyone. Thanks so much, Barbara, for this introduction. It's a pleasure to be here with this panel today and to be joining this conference. Again, it's just a real pleasure. Barbara, I think sort of COVID has really made us all realize that health is integrated and integral to the whole human experience. So we cannot really separate health or public health measures from social and economic implications and social and economic measures and that responses and policies that need to be in place to respond to these to a pandemic of this proportion. It also made us realize that inequalities that have been festering for many years and sometimes decades are now showing up in terms of the impact of the pandemic on certain populations and in certain countries and within the same country. So I think issues related to inequality, social and economic implications, and also the importance of combining or not being limited to just medical countermeasures. We need to look more at systems approach, a whole system approach, and also to the contributions from social sciences to respond to the pandemic and to prepare for future outbreaks and health emergencies. Maybe my final point will be on the role of what made what became important also is really understanding the gender dimensions of the pandemic, not only in terms of how women are being affected and how poor women in particular are being affected, or refugees, but all or displaced populations, for example, but also how women scientists are being, the role of women scientists in the response to the pandemic, and how we as donors can support a bigger role for women scientists now and in the future. I'll stop here. Thanks so much, Barbara.
Okay, thank you very much. I think that's clearly a major insight, I think, around inequalities and gender issues. May I pass now to Benjamin Levinson? What is the Global Fund thinking?
Thanks, Barbara, and hi everyone. So I guess there are really some challenges, in health systems. In the context of COVID, we really need to look for interventions that will increase the resilience of health systems, and by that I mean the ability to deal effectively with pandemics or other shocks that systematically affect the system. I think we also want to look at interventions and approaches that will be helpful regardless of the pandemic's trajectory. It's very difficult right now, based on what we know, to figure out exactly how the pandemic will play out. We need to find things that will be useful no matter what the trajectory looks like. And then I guess the third challenge is how to look for and find approaches that are what I would call dual use, that they're useful to the pandemic, but regardless of what happens with the pandemic, they're useful going forward in strengthening health systems more broadly. I think there are 3 or 4 areas that are really important in this context. One is doing a better job of tracking service delivery at the facility level, at the where services are being delivered. I think there's a real need for health facility surveys, and this needs to be become much more of a common tool across the world. And we need to do them with a frequency that is sufficient to actually make course corrections. So instead of doing episodic ones, maybe we can do them more frequently. A second area is really making sure that we get funding down to the facilities, to the people who are actually doing the work. People have known about this problem for 40 years and was the basis for the Bamako initiative and other things. But unless we get money down to the people on the ground, we're not going to be helpful to them, and they're going to be less resilient and less able to deal with the problems that they face. This approach of direct facility financing worked very well during the Ebola crisis and needs to become much more common. Some countries like India, Tanzania have dealt with this, but this is still it's a minority of countries that have really decentralized and their funding right down to the facility. I guess the third area I would look at is where we take advantage of the private sector, NGOs and civil society organizations much better, and look at some types of performance-based contracting. This has worked out very well in Afghanistan, and their ability to be resilient in the face of insecurity, and also, I think, in terms of their response to COVID. So those are 3 areas where I think we really need to, raise our game and understand more to be helpful to the countries and the people we serve. Thanks very much.
Thank you. I'm sure those are themes that are going to be reflected across the conversation as well. Resilience, dual use, I think, is a really important concept, and I definitely want to come back to that. But also engaging the private sector, especially the non-governmental and civil society organizations. But let me move on now. Loda Adedokun, tell us all a little bit about how Doris Duke is thinking about these issues.
Thank you. I think some of my comments will hopefully reinforce Benjamin and Monteser's comments as well. So our foundation is US-based, funding in sub-Saharan Africa. And our dollars have really been directed towards building a platform to really protect time for researchers to really engage directly with the system. The sort of traditional dynamic for research has been researchers sort of do their work and produce their products after years, and those products land on a shelf. and are rarely really absorbed, adopted, and utilized by the policymakers and practitioners. So really rebuilding that dynamic, strengthening that dynamic that really brings together policymakers, practitioners, frontline workers and researchers in the same space and place to really answer questions that are being that practitioners are facing on the ground is going to be crucial. Be there a pandemic or a crisis or whatnot. I think that's at the heart of really building what is a resilient system. I'd also note that implementation research in particular is a methodology of research that is really underfunded, but really is that critical research that answers the how and the why, not necessarily the what. We have so many solutions that already exist, but the critical challenge is how do you deliver it? And why is it not working in a certain place, or why is it working? So really unpacking those will be, I think, critical going forward. I also want to note that we can't forget the role of politics and policy. So we need to, I think, and we're pushing for this, to really face, I'm calling in from New York, and politics has been a critical issue and an adequate, an appropriate COVID response. And if we do not tackle those issues and name them and document the role of politics and sort of the different policies that were put in place in different spaces, we will not be able to really inform resilient systems. And I think my final point related to that is the role of messaging. I think researchers and policymakers have a crucial role to play in ensuring that they are messaging key issues clearly, consistently across the board, rather than, again, it's related to politics, sort of leaning into certain misinformed decisions. So I think as we look to the future, really arming our researchers with that capacity to communicate, message, high-level points will be critical as we move forward in an increasingly complex environment. Today it's COVID and it's ongoing. Our climate issues are going to become critical in ensuring that, and enabling systems to respond and really, setting them up to be responsive to local needs. So, this is one crisis that has really surfaced the many issue areas that we need to address, but we need to really use this moment to begin planning for a better future. Thank you.
Thanks so much, Lola. Again, I think themes that we'll be returning to. Avoiding the shelf is a constant need to be remembered in health systems research. None of us want our work to languish on shelves. So how do we make sure it's relevant? Very exciting to hear intervention research and implementation research are the types of things that you're going to prioritize. And absolutely, I think if ever we needed an object lesson in how politics and political leadership are critical, we just had one. So I think thinking about how to research that is, of course, another set of challenges. But let me move on now to you, Feng Zhao. Perhaps you can give us some ideas about how the World Bank is beginning to get its head around these issues, if it has one head.
Thank you, Barbara. Very happy to be here. Just one quick correction. My job title and responsibility had changed. I'm the practice manager for the Health, Nutrition, and Population Group at the World Bank. So I'm part of the team in coordinating our COVID-19 response. The topic of this symposium is of highly interest to the bank for two reasons. First, as many of you know, starting in 1996, we have positioned the bank to use health system strengthening as a main angle for our support to our client countries. So all our global, regional, country operations, policy dialogue, and analytical work has been evolved around health system strengthening. So that's the one angle I just want to make it clear. So that's have significant relevance to the audience here. The second thing is, let me turn off the other speaker. The second thing I want to emphasize is that bank built on the past pandemic experience, we have taken rapid response. The response has been unprecedented. Just give you an example, within 100 days, we have allocated $6 billion, has reached more than 100 countries. So that's so-called 100 by 100 initiative has really bear some fruits. On average, a bank project was prepared in the length of 1 year, and for a COVID project, so we use probably 1 week to deliver. So so we have a platform now. We have more than 100 countries have the bank financing in supporting COVID response. Intentionally, we also designed a small part of it in addition to emergency response. About 20% of our financing are used for system strengthening, analytical work, and policy dialogue, and can be used in medium term and long term. So that's a platform which is already there. Recently, the bank announced $12 billion for vaccine and vaccination programs. So that's a new initiative to support the vaccine delivery system and make sure they are ready first. And then once the vaccine become available, particularly those low-income countries can use the financing to procure and access vaccine. So one message I just want to share with this group is the need for integrated, evidence-based, adjusted investment framework in health systems. During the pandemic, what captured the media is really the ICUs, hospital response, ventilators. That actually provides some wrong impression, particularly to our finance ministers, that that's the area need urgent and increased investment. There's a lot of soul-searching question has been put on the table, particularly from our colleagues from Ministry of Finance and Central Bank on how we invest the future health system. So this is a big agenda. We in the bank, we really want to communicate with the finance ministry, which is our key clients, on an integrated framework, which can include roughly 3 tiers for their consideration for investing in future health system. The first one is really the regular health system, which strengthens the public health function and surveillance function, which can serve as a system which can alert before the pandemic started. As you know, the current setup has failed us in terms of preventing this COVID-19 pandemic. In the future, how can we do a better job collectively to make sure we can capture that, sort of winning the quiet war, not the chaos we've seen on TV at hospitals. That's a great agenda. The second one is really the typical epidemiological public health measures. Once we have outbreaks, how can we contain it in the early phase? Use contact tracing, use testing, and use all those public health measures. So that's the second tier need to be strengthened, whether countries are ready for that. The health security index, which we have, really predict poorly about the country's performance. We see many countries ranked very high on health security index, performed poorly. So how can we create a research agenda and provide evidence to our future actions, future investment? Lastly, I want to emphasize health system and COVID-19 response are not dichotomous, and they can be integrated. There's many research agenda embedded in COVID, which can be rethinking, reprogrammed, or finding new angles for us to work on that integratedly. The bank, we put a platform in place, now have over 100 countries with financing. A lot of those financing, if our country clients, government willing, can be used for research, for system strengthening, but they need to be operational and guiding country-specific policies. But I do see the system will serve as an enabler to support all the future pandemic effort. Without research evidence, we will run into the same panic and neglect cycle. I think the evidence and research can guide us moving forward. Let me stop here.
I think I was muted because I've been coughing. Thank you. That was, I thought, very interesting on a number of levels. I mean, I think one is just reminding us just how important the bank is and the scale of its investments in this area, but also its links to finance ministers outside the Ministry of Health. And I think we may come back to some of the issues of the extent to which COVID may be raising health and health systems in political agendas and giving us some new opportunities. But I also want to come back when we get into the conversation to that point about the Health Security Index. Basically didn't predict what it was expected to predict. And I wonder if there are a wider range of things that have been invested in the past that now look like they haven't been well targeted at what was really needed when the crisis hit. So that's something else I'd like to come back to later. But before we get into that, picking up these themes, may I go to our final panelist, Dr. Ghaffar. Could you tell us a little bit about how the Alliance is thinking about this set of issues? Thank you.
Thank you, Barbara. So thank you. Good morning, good evening, good afternoon, wherever you are. So Alliance, as you know, was established like 20 years ago, more than 20 years ago, with the sole mandate to promote the generation and use of health policy and systems research for the stronger health systems. So over the last 20 years, we have invested most of our resources in strengthening the capacity of the researchers, primarily in the LMICs. But for the last 7-6 years, we have also started investing into the capacity on the demand side to like use the knowledge for policy planning and the stronger health systems. However, the most difficult thing which we have faced is like changing the mindset, which is the prevailing mindset is like, okay, research is very different than the research for which is embedded as part of the programs. And that's what we are working with the colleagues, especially with Lola and her colleagues in Africa, but also with to a smaller extent with the World Bank, with the Gavi and the Global Fund growingly now. And even within the WHO, we have to make a case that why shouldn't we have health system research, implementation research, policy research as part of the programs. And I think that is what we have to pitch, that if there's a money for the stronger health systems, there should be embedded money for the research within those programs. I understand the Gavi and the Global Fund and even the World Bank, if the countries, they want to write as part of the proposal, you can have it. But I think we need to have it into the national budgets, not as a separate thing, which is like a research program, which are very separate. And the mindset of the policymakers for the research money is very different, especially in the national policymakers. So that's the one thing which we're trying to change the mindset. Excuse me. So second is we have invested a lot over the years in developing different methods, guides, and readers. Like we have for the teachers, for the trainers, for the policymakers, for the implementers. And before 2007, there was no methodologies for the systematic review for health system research synthesis. There was a very robust methodologies for the systematic reviews for the effectiveness. So then we started supporting some systematic review centers all over the world. And now we have reasonably robust methodologies for the rapid reviews of the health system research or the health system research synthesis. So similarly, we have developed other guides and those things. One of the things I think after the COVID, we have realized that there has been some sort of a like artificial divide within the health community, that this is emergency community, this is emergency response community, this is infectious disease team, this is like policy team, and that has completely melted down because in the COVID, every country, and I think we have coined the word resilient health system after Ebola crisis, but I think those countries which we thought are resilient has melted more than the countries we think they are not resilient, they don't have the resilient health system. So every country has faced the challenge of the epidemic, but also the challenge of maintaining their essential health services and the primary healthcare systems. And that is, we have invested some sort of the resources based on, because, as I said, we are working a lot with Lola, that what is the demand-driven research? What are the research questions or the priorities for the policymakers? Because if you ask the same question with be different answer from academic, no offense to academics, but they think very differently when they have to think what is the research questions. But if the same you ask a policymaker, it's a very different research question. So you're working with 20 countries, and they have identified like some research questions which they think they would like to have the answers, and we will have the early answer by end of December. That ranges from like distribution of masks and the ventilators, which was not historically the domain of the health system research community broadly, because in the last 20 years we have invested, I think, mostly in the 6 building blocks, and we have not looked beyond 6 building block as a health system research community. And I think the time has come that the health system research community should stretch beyond these 6 building block boundaries. People have invested from the system research community into the emergency, but remotely. So I think we need to invest in the healthier population application of the policy and system research, in the preparedness, but also into the emergency system, but continuously to invest into the essential health services, which is quote unquote 6 building blocks. So that is where we are investing now. But I think we are also very cognizant that we should not be completely swayed with this epidemic, because we need to look for the systems which are equally effective and responsive to the routine health services or the essential health services. Those are not compromised, because the most of the money which is flowing in, especially from the big donors, is to invest into the response and into the emergency and all those things. So that is where we are doing some sort of mindset change, some sort of collaboration, coordination, working with the friends and the colleagues, but also investing in the capacities and some generation of knowledge. I will stop here, Barbara.
Oh, thanks very much, Gafar. And I think that tension, if you like, between emergency and long-term system building is something that I think frustrates health systems people on a regular basis. Whenever there's an emergency, we might see it as something that the health system might have helped prevent or could have helped respond better to. But we see funders tending to look at short-term fixes for the emergency. And I do think maybe with COVID, there's some reasons to think that won't be the only kind of response, in part perhaps because we're all affected and not necessarily in ways that we might have predicted if we were to know that this had been coming a year ago. But let me pick up on some of those themes now and explore them all in a bit more depth. Let me go back first of all to that theme of inequalities and gender. When we're certainly seeing those themes play out very clearly in the context of COVID, aren't we? But I'm wondering if there's any reflections on the extent to which the work that has been done in the past on health policy and systems research in relation to inequalities and gender is seen as, whether you see it as having given us the background that we need to be able to tackle those issues better now, or whether in fact we needed to address those issues a little differently, or we've got some new perspectives on those questions. Montasser, you raised those in the first place, so let me turn to you to see whether you think that COVID is giving us some new understandings or some new questions about inequalities and gender, or whether we really have built up the right body of work that enables us to answer those questions in the COVID era. Thanks.
Thanks so much, Barbara. I think there is definitely I would say a nucleus or a base that we can start from. There has been research, especially in the past, I would say 10, maybe 20 years, on differences among different populations. But I think where we are learning during the COVID era is we cannot really look at one form of inequality in separation from other forms of inequalities. It's people's work, where people live, their circles, their work circles, their work environment, access to resources. These are all important factors and determinants that they interact with each other. So we cannot really study one and not the other. And I know for research, this represents, a challenge, because we like to separate, kind of categorize and separate and study in depth. But the reality is people's lives, as COVID has, most recently demonstrated, is much more complex. And we really need to grapple with that and come to an understanding of how that can be, how that complexity can be reflected in the research that we do and the research we support. One of the other forms of one of the other questions is, for example, related to financing. That also came up has been coming up during COVID-19. How people are, how people's access to resources, whether it's even tests or treatment, is affected by what financing system that exists in a country, for example. So these are we have, so there has been, of course, been some research on this, but not in the context of a pandemic. Is a public health system, a publicly financed health system, does it perform better in this context or not? What is the role of the private sector? We have always looked at the private sector as a potential collaborator, and in some cases, as we've seen now in the vaccine development, kind of a really hand-in-hand partner. But in health system, that's a different approach is probably required for this. Maybe the last point I'll make for now is how do we the role of health workers. It's really kind of, how to say, a reality that in many cases, frontline health workers, especially if they are women, especially if they're at the community level, they are doubly tasked with, or doubly, they're tasked with many things, but they're less appreciated. The inequalities that they are suffering from or not being treated equally has an implication on how a robust health system at the community level can be effective and can be responsive in times of pandemics. So there are forms of there's a good foundation of research that we can start from, but we definitely have a long way to go on a number of issues. And maybe, sorry, one last point: information systems and data systems. We also realized, that as one of the important building blocks, and how that is important during COVID-19. Data early on, very early on, from the UK, from other European countries, and later on from other contexts in Asia. It was observed that mortality was not what it was counted to be, because the data comes later on from civil registration and vital statistic systems. So unless we have all the systems in place, rigorous, universal, accessible, we really cannot say we have a robust health system to carry us for the future, for recovery and response, and be prepared in the future. We need to invest in those things. Thank you.
Thank you, Montasser. A lot of really important points there, and really underlining how complex are the issues of inequalities and how they reverberate across so many different domains. But I think also that last point about information systems, a rather neglected component of the health system, suddenly becomes very clearly a very essential, if not the most essential component. I mean, difficult to say the most essential, and I'm sure there's a whole lot of work needed to be done on information systems, because there hasn't been a lot in the past. Benjamin, I think you have some thoughts on the subject on this subject.
Yes, thank you. And I just wanted to pick up on things that you and Montessa were saying about the measurement piece of this. I mean, the thing about inequality is that it's not going to, you have to go and look for it. It's not going to sort of come to you. Routine information systems generally don't capture very much information about inequality. So we really are dependent on surveys, on health facility surveys, on sample registration systems or demographic surveillance if you really want to get this kind of data on inequalities. And so if you don't look for it, you won't find it. I mean, it's not gonna jump out at you. You need to be proactive. I also think that there's I mean, it's not good enough just to document that things are unequal and that you know that the inequities are widespread. It's also tracking over time whether they're getting any better, and even more importantly, what do we do about them? What are the potential interventions that can really address some of these important inequities? I think we at the Global Fund, I think we've underutilized things like conditional transfers, cash or other goods to get people into care and stay in care. And it's something where I think the evidence is very strong, but I think it's been underutilized. So, I mean, not only do we need to use traditionally available interventions, we need to look for new ones as well and find out what's really working to improve equity in health service delivery. Thanks.
Yeah, thanks. And so much data are not disaggregable, and that means that we're not able to track the trends that we would like to be able to track, as you're saying. Let me go back a bit to the theme that you raised, Feng, about the priority of health systems in larger government. And I'm really interested in your insights as to whether you think that there is, in fact, a clear, greater recognition of the importance of health systems in the wake of COVID, or are people really thinking, well, it's not really about health systems, it's about closing borders or policing the population so they lock down, or managing livelihoods so that people can lock down? What are you finding as you're talking to finance ministers about what might be the priorities for health systems research going forward?
Yeah, this is still an ongoing conversation. I think the debate around a few key areas. One is the health intervention versus economic social intervention, right? So, the debate which between our epidemiologists and economists are still there, although it's converging, but the divide is still there. I think we'll have to have an integrated approach. I mean, when we approached our response, of course, our first phase, the 6 billion, is really for health emergency. There's no question about it. But even within that, we sort of considered some of the limited evidence at that time, in addition to all the emergency measure short term, but we also want to factor in some medium term and long term system building, preparedness and prevention. So we convinced our board to have about 20% of the fundings in that regard. So that's for the first phase. The second phase package of the bank response is much larger, is for economic and social response, is 160 billion. That's for economic recovery and all that. This is really zoom into country-specific economic recovery measures, and also support the vulnerables. Some of the social assistance program was included. That part really, it's country-specific because the country is so different. A lockdown in the States is largely vastly from a lockdown in Kenya or in Nigeria. So there's so many country-specific factors to consider. In there, I have to say we struggled quite a bit in terms of finding the evidence linking, some of the research. We understand this is something happened very fast. There's a lot of uncertainties, but one point we really need help in terms of guiding our support is the quick linkage between research community and the operational financing community. so if the faster, the quicker we can make that link, the greater good we can achieve collectively. One thing we have been communicating with Ministry of Finance, particularly during the annual meeting, which we are in the last part of the annual meeting. So a lot of discussion has been on the health security agenda, not short term, but medium term and long term. There's a collective thinking on how we do a better job in terms of addressing future outbreaks and pandemics. A lot of those measures are not short term. For example, One Health agenda was heavily emphasized. So not just human health, but also animal health, which is the root cause of this pandemic. And many, 70% of the health issues we are dealing with. So that's another huge research agenda area. Integrating public health function into primary health care and have strong surveillance system is another area. Investing in the 3-tier system, as I mentioned, it's also critical. So in the bank, we plan to continue that dialogue. We plan to have an annual flagship platform so we can talk to finance ministers in a regular sort of ongoing manner as one of the specific measures to break the panic in neglect cycle. So that's one thing we want to continue to build that bridge. But one thing come to clear is the connection between our research community and the global work and country work we, Global Fund, Gavi, and other international organizations are doing is much needed. Let me stop here.
All right, thank you very much, Fang. And I think that all, to a certain extent at least, relates quite strongly to the issue you were raising, Lola Adedokun, about politics and the importance that politics is playing in all this. And I think we can all, as I was saying earlier, see that that's clearly the case. What are the research questions? What don't we understand about that we need to understand? And will your foundation be interested in work in that area?
What don't we understand? We don't understand quite a lot. But I think one way that we can overcome the sort of influence of politics on decision making is to truly invest in the local research institutions that can be more responsive, and moreover, investing in the leadership and governance at all levels of the system. Typically, we lean into national government and their national response, when in fact, the highlights and the most successful interventions or examples of that happen at the district and provincial level. And that kind of facilitating, incentivizing those leaders who understand how to navigate a complex political environment successfully, that is going to be the key point at which all those elements that we're talking about, investing in health facility surveys, investing in sort of coordinating the financing mechanisms at the local level. That's where the sort of enduring, I think, enduring investments and real solutions can be made. Even from in our investments, we have made, and I think all of our colleagues have made those critical local investments. Unfortunately, they tend to be more one-off, we'll talk about one pandemic or one sort of high-level issue that comes up, and no longer sort of invest continuously in supporting those platforms. So, it would behoove us all as funders to internally reflect on how we fund to ensure that we are really investing in enduring in local institutions and local leadership. That's going to be the answer. I think for our historical investments, our legacy has been in building those platforms where there are researchers, policymakers, practitioners who work together as colleagues, know their lane, but also know their individual and respective power. One would hope, especially at the primary healthcare level, that we can work together to ensure that financing from our perspective is better coordinated to continue on with that legacy. And of course, lean into the leadership of our global bodies, including the Alliance, to promote that investment in leadership and to highlight and give them the profile and space to name where those successful interventions have occurred.
Yeah, I think there must be lots of interesting lessons emerging about how local level governance is making a real difference on the ground in all sorts of places. And probably a lot of lessons from low and middle income countries where those kinds of things have been more overtly encouraged, perhaps. Certainly, I think it's pretty humbling as a British person, for all that I'm someone who sits in Australia, to see how our politics have been completely failing us there in the context of this, and how countries with much lower levels of resources are doing so much better. And I think documenting that and understanding what it consisted of would be really, really important. Gafar, your group has done an awful lot of work around what goes on at local level in the health system and its importance. Do you think you will be seeing a lot of that kind of work emerging with Alliance support, or do you think you already have, if you go back to the question that I asked Montasser before, do you already have the body of work you needed because you've been investing in just the right research in the past?
Thank you, Barbara. I think, see, the good thing is, I think world has never appreciated and realized before, maybe 100 years ago, the importance and the role of the health. And within health, I think people have started appreciating the role and importance of health system, whatever the definition of the health system people may have. So within that, I think there's a lot which needs to be done, because there's a lot of knowledge which is available, but it's not known to or used by policymakers within the, especially in the LMICs. So it's not an issue of the knowledge availability. There is a knowledge available, but it's not known to or used by the policy and the decision maker. And I think that's the effort we need to make. Can we connect the policy community or the people that they understand the value of the science, and that science which they think is useful for them, and that knowledge which is useful for them, and that is for the stronger health system within this environment or the earlier environment. And I think that is where we have to invest more and more. And there's a very little investment from the national government in generation of contextualized knowledge which can be used for the stronger health systems or for improved policies. And I think that's a challenge we are all facing at the national level or at the country level. But at the same time, we have the same challenge at the global level, that we have all different priorities and different maybe governance system who demand very different outcomes of the output from each entity. And we need to align our resources and effort. When I say resources, not the money, it is the intellectual resources, it is the goodwill, and it's the position and the power of each individual agency to align towards that. We need to have more and more local knowledge, which is useful to improve the systems and policies in those countries.
All right, thanks very much. I think we've had quite an accumulation of questions from the participants that I would like to turn on to now and make sure we have time to do those justice. Might I start with a question that I'm sure is important to a lot of people who are attending today, and that's what the funding opportunities are actually likely to be from your group. So how can we learn about them? What are they, and will they particularly relate to health policy and systems research through a COVID lens, or will you be maintaining the usual channels without opening up new COVID focused lenses? Let me go to each of you in turn on that. And again, Montasser, can I start with you? What's happening with IDRC? What are the opportunities that some of our participants might be interested in?
Thanks so much, Barbara. During this year, we had IDRC dedicated the vast majority of its resources for COVID-19 research in LMICs. And these were through a number of calls. And some of those calls were joint with our sister Canadian organization, Canadian Institutes for Health Research. So there were several opportunities this year. We are discussing plans for next year, since our resources were depleted already this year for research on COVID and COVID-19 related issues. So I think there will be, if there are opportunities, hopefully there will be more opportunities. And some of those opportunities may be related to some short-term measures. Some of them hopefully will be also related to kind of like long-term preparedness and resilience building. Some of those ideas are in the works. I don't have exact dates for those, but definitely please follow our website, idrc.ca, for those for the majority of those opportunities, and we welcome being connected, hopefully in the future on that.
Thank you very much. Benjamin, the Global Fund doesn't often, at least, advertise research funding opportunities that are directly accessible by researchers. So do you have any advice to our research community about the routes by which they might be able to find some global funding for their research ideas?
Yeah, I know, Barbara. I think that's right. I mean, you're basically right. You know, it's a little bit follow the money. Where's the money in the Global Fund? It's in the grants to the countries, and those grants are formed and shaped by the CCMs, by the country coordinating mechanisms. And so, I mean, if people have interest in them, they can and should approach, you know, their CCMs. You know, for these opportunities. Right now, I mean, countries are in the phase of grant making. They're finalizing the grants right now, and there can and should be, you know, sort of opportunities there. But I admit it's not easy. We do have something called strategic initiatives or catalytic funding, and we will be over the next few weeks issuing RFPs for researchers and research institutions to carry out evaluations of some of the things that some of the innovations that we're trying to push forward under these strategic initiatives.
Thank you. And Fung, a bit similar with the bank, you don't advertise research funding direct to researchers very often. What are the opportunities that people might have coming through the bank for being able to fund some of the research ideas or support governments with some health policy and systems research?
Yeah, so so we have a country-based financing model. So that's sort of the mandate of the World Bank. We lend money to mid-income country and low-income countries. So within that envelope, a lot of those projects was before COVID. We have our health system strengthening universal health coverage programs. Many of them supporting health reforms. So research is embedded in that. Before I took on my current job, I was in Ukraine for 4 years when Ukraine was going through the health reforms. There's a lot of research agenda built into it, how to sort out the payment scheme, how to resolve the over-hospitalization agenda. So the many research agenda built in that. So the bank financing can support that. That's a health sort of country-specific model. In COVID, as I mentioned, we also have the health system component built into it. So if country level, you know, government has a big say on it, want to do some operational research and need some evidence for policy making, so that mechanism is there. So in addition to that, I mentioned there's a few global initiative which is within my team. We are moving forward. I mentioned we're designing a flagship for ministers of finance, so take advantage of the World Bank, IMF annual meeting and spring meeting. So every year there's 2 opportunities for finance ministers and central bankers gathered in Washington. So that's a huge opportunity to have a dialogue with them. So we're designing a program, a really evidence-based program, to communicate with them what's the sort of post-COVID where COVID-related investment framework. So that's one research agenda which is in which is ongoing. Again, similar to Benjamin's point, we also have all the research related or hardware related procurement all posted on the World Bank website, so you can look through them. There's mixture of country-specific research need. There's a global programs, so there's a lot of information there. Can be a start. Over.
Fabulous, thank you. And Lola, you outlined some rather exciting ideas about some things that I'm hoping that the Doris Duke Foundation might be going to fund. What's in the pipeline there?
It's yet to be determined. The challenge, there was a question in the chat box about, not every funder is the same. We're all very heterogeneous, which is very much a fact. So we are, especially on this panel, a small funder, relatively, but very targeted in how we invest. I think as we look to the future, our partnership with the Alliance has been really fruitful. Of course, we've chatted with some of our colleagues here on the panel. We will not go anywhere alone, nor will we focus on a specific health area. Our interest is more in, again, understanding how systems work across the board and responding to health crises. So we'll be thinking through the opportunities internal to our foundation and other private funders to see what opportunity there is. And I would suggest that we'll name it on our website, but we'll probably use a platform like the Alliance, which has the broad reach that we seek to communicate what future opportunities that there might be.
Thank you. And finally, Gafar, what will the Alliance be advertising for people to apply for in the coming months?
See, Lola said she is a small funder as compared to the World Bank and Global Fund. So funders, so you are kind to invite us. So we do fund a little bit of research, but those are usually small grants and the money we receive from the big funders. See, what we are doing, we are issuing a big call, which is like exactly looking how the countries has been able to preserve the essential primary healthcare systems and also able to respond to the COVID-19. And the thing, as I was saying, we have been investing on human resources for health, healthcare financing, role of non-state providers. That was the support from the IDRC for a couple of years ago. But we want to go beyond and see how the broader health system, and I think it also came the word essential public health functions, which Feng Zhou said it. And like a couple of years ago, we had a Bellagio meeting on the essential public health functions. And I think we need to have a clarity within the funders that what are the best investment where we need to have a knowledge which can ultimately help some sort of the direction. And as the question has said, and the Benjamin was also saying, every funding agency has a different mandate, mission, and the reasons. But at the same time, we need to have some sort of a broader agreement within the funding community that what sort of the knowledge base we want to promote and generate and have a repository for the health policy and systems research practitioners so that they can use it for policy planning and the implementation. So for me, the question of funding, I will not say anything that we are issuing a call, but that's a call, maybe $1 million total budget, which is not as significant, but significant for the health policy and system research community, especially in the low-income countries. But we are very happy, as Lola was kindly saying, to work and collaborate with some of you. And that's what we'll keep on doing, because I think there are a lot of areas where we still need to make some sort of investment, especially in the capacity, if not into the particular topic.
Well, thank you very much, all of you. I mean, we've got a little more than 15 minutes left, and I know that I wouldn't want to conclude the session without having grilled you about the funding opportunities that might be in the pipeline. But let me take a few steps backwards, since we do still have 15 minutes. A number of other themes have been picked up by the questions that people are posting. We can all see them, so I won't read each individual one out. But there are further questions around inequalities, around data and disaggregation, and around perhaps both related to the dual purpose idea that Benjamin raised earlier, and the emergency versus long-term development idea that Gafar raised about the sort of tensions between that and how those can be resolved. So let me perhaps just, I think we've probably got time just to go around you all once more to pick up on any of that that you would like to. As I say, you can see the questions that are in the box. Do feel free to rove across them or pick up on a particular one. And maybe I'll just go backwards this time and start with you, Gafar. Is there a question or a couple of questions that you'd like to pick up on from the chat box?
So thank you, Barbara. So I think the one thing I, as somebody who has worked in the government in a developing country and has also been part of the academia, I think it's important that we have better data system. It's important that we have better disaggregated data system. Absolutely no issue. But I think we need to also invest more and more resources wherever the data is available, that disaggregated data, data which can show that this is what is happening for the policy dialogue. And we have not invested into that type of research, which maybe somebody can call marketing research, it's a policy research, research on policy. But I think that's very important, that whatever we do in the health policy and health system research community, that availability of data is an issue, but wherever it is available, either the global or the local, we should try to make sure it is known to or used by the policy and the decision makers. So we should be able to present that data. And I think that's another area of research where we need to invest. What are the different mechanisms most to do that? And the ideal world, obviously, we should have a system which is like, I was going to say perfect because there will never be a perfect system, but there's a system which is pretty good while we are having the routine health services or the essential health services. But if there is a situation where they have to anticipate and respond to an emergency or any other shock, that has to happen. My worry is we are trying to position ourselves within the WHO as a health policy and systems research team, that the world should invest more and more into the system so that if there's an emergency or if there's a routine, the system should be ready. And I think the closest I was hearing was from Feng Zhao's comments from the World Bank, that they are willing, World Bank is going to make a lot of investment into the health systems of the countries. And that may be somewhere we have to align the forces, that while we are putting money for strengthening health systems, we need to make an investment in the local knowledge and the contextualized knowledge, because every country has different systems and different responses, either based on the power, which Lola was saying, or based on the culture and the systems which are constructed over the centuries or the years. So I would personally, if I have the choice, I would like to invest more and more, in your words, long-term development into the systems.
Thank you. Lola, can I go to you next?
Sure. There was a question in the comments about the power dynamic, how to ensure that funders are truly responding to local needs. And one can't sort of reinforce enough the fact that countries really do hold the power. If there's a consistent, coordinated demand for a certain type of research, especially if they're utilizing these CCM platforms or these sort of coordinated mechanisms to articulate what research is critically important at the country level, using that will be key in ensuring that resources are made available for that research. So I name, most of our funding has been in sub-Saharan Africa. You think of countries like Rwanda, Ghana, Mozambique, where they really do have a coordinated mechanism for advocating for the kind of research that's needed. And they will not accept resources or, really, just respond to a funding call if it doesn't meet their country priorities. So, reinforcing the power that national governments hold and demanding resources will be critical. again, especially when it's coming for private funders like ourselves, you know, those kinds of resources are more flexible, and also the design of programming dollars is often done in partnership, close, authentic partnership with local partners. So that's really leaning into that power will be critical. And I also want to just raise one final point around the high income, low income country distinction. I think COVID-19 has highlighted that demarcation between high income and low income and the response. It really put that into question. And I would say that there's a critical opportunity now to shine a light on successful responses from quote unquote low income, low resource settings that outperformed responses in high income countries. And the fact that now we can use that as an opportunity to really share the research leadership in sort of furthering more pandemic related responses. So there really is it's an interesting, I guess, democratization of intellectual power and leadership that we should take advantage of.
Thank you, Fung. Can I go to you next?
Yes, I want to build on what Gafar has said. There's a lot of work has been done. One agency can play a key role in coordination is WHO. I really hope we can build on what has been done, not sort of starting something completely new. I'm intrigued by the Bellagio discussion you mentioned. If you can share that, that would be great, because we are really looking into how do we integrate public health functions into system strengthening. That's a critical agenda, not only for research, but for future investment. Of course, I said communicating with not only ourselves in the health community, but also those people who allocating budget, deciding resources are critical in the way forward. There's a lot of evidence has emerged. We don't want to, give the wrong impression, the wrong place to invest. So that's, we have a collective interest, both the research community and also the financing community. That's one agenda we need to work very closely together. And also there's global mechanism. I don't know how many colleagues here have heard the ACTA initiative, Access to COVID Tools Accelerator, which many of the key global and regional partners are part of it, and many of the government's agencies also part of it. There's a lot of discussion on those issues already. So Global Fund and the World Bank are co-chairing the Health System Connector Group, which we really want to make a connection between the key COVID tools, vaccines, therapeutics, diagnostics, PPE, oxygen, but connect them with the enablers, what we call, which is the key building blocks of the system. Linking this two, I have to say, is not easy. It takes a lot of effort, particularly when it comes to fundraising advocacy, because there's a debate saying we should focus on those tools, but on the other side, you cannot move forward without those key enablers. So the back and forth discussion really need emphasize the need for research down the road. I just want to wrap up my point just with a call also for WHO and other alliance, maybe clear key role to disseminate what we have done, so we can all benefit from those researches already. Let me finish here.
All right, thank you very much, Fung. Benjamin, your thoughts about any of the issues that have just been raised?
So I have at really different levels of the healthcare system. I mean, I think, the whole, our investments previously in health information systems the best place to use data is where it's collected and where it's been created at the health facility level. And the more we focus on strengthening the ability of people at that level to use their own data to improve service delivery, the happier everybody will be, including our patients and communities. So I think there's a whole, I mean, there's a lot of research in this area already, but like quality improvement approaches that use data that already exists and use it better at the facility level, it's really the short route, because those people, when they find a problem, they can solve it if we give them the resources. So that's at the lowest level. I would go then really sort of right at the other end of the scale. I've been very impressed. I mean, the Health Results Innovation Trust Fund at the World Bank really invested a lot in very rigorous evaluations of performance-based financing and decentralized facility financing. And people said it was too much, but I think that the learning from that is so rich and so important that it really is behooves others that when we spend huge hundreds of millions, billions of dollars trying to improve health systems, and if we don't learn the lessons from it, we're pissing that money away, and we really need to capture that learning. And sometimes it'll involve randomized trials, but it could also involve things like interrupted time series. So I think this is doable at a cost that is reasonable given the scale of the investments that we're talking about in health systems, both by development partners as well as by government using domestic resources.
Thank you. And finally, Montasser.
Thanks so much. My colleagues have already said all the points, most of the points I would like to make, but maybe I'll add a couple of points, and maybe in response to some of the questions also from the participants. The first one is really about the sort of how do we help health sort of governments prioritize research in their response as well. I mean, this is something that is hard in any given, under even normal conditions. So I think, building on, there are emerging global research priorities. I think working with governments to translate that at the country level to country level priorities is going to be very important in the future. And I think it's one of the things that will probably be hopefully looked at more in terms of funding at the country level going forward, not just global research agenda, but country level research agenda. There was also another point on sort of the data and information systems, and ideally universal rigorous health information systems and data systems can capture inequalities. The reality, capture full information and inequalities. And the reality is most of the systems do not capture that. Cause of death is registration in Africa is a single-digit percentage, for example, in terms of accuracy and in terms of coverage. These are things that we need to build and support for the long run. And as I think Benjamin, who said, kind of like for dual purpose. This is not just for building those systems for COVID, but for future development planning and the national planning. My last point is really about user perspective. In many of the situations we have seen, or many of the responses we have seen, whether it's in terms of research or whether in terms of actual kind of programmatic responses, the user's perspective is not always there. And I look at, for example, whoever decided universally that access to sexual and reproductive health services is not essential health services, I think certainly did not ask the women what they consider as what is essential health services for them. So having user perspective, be it women, being disadvantaged populations, being refugees or displaced populations, is going to be really important in the future in determining our priorities. Research priorities, but also hopefully our investment priorities in the future. I'll stop here. Thanks so much, Barbara.
Well, thank you very much, everybody. I think we're just about out of time. So I would just like to thank really everybody for what I think has been a very useful and interesting and thought-provoking conversation. I think a number of key themes have emerged, and I think we've explored them in some depth. I'm sure we could have spent another hour exploring them in more depth if we'd had the chance. And I'm sure everybody was excited and intrigued to hear about the various ways in which they could potentially access funds for health systems research in the COVID context. So I'll draw a line under it here. Thank you very much, everybody, for coming. Thank you very much to the panelists, and good night. Well, good night from Melbourne, anyway.
Thanks very much, Barbara.
Thank you. Goodbye.
Bye-bye.
Thank you. Goodbye. Goodbye.